Greetings and welcome to this video on Clinical Pharmacology Series, Analgesics, a physician's perspective. So, physicians being the most important person using analgesics for various purposes, from headache to body pain to knee pain to back pain and other visceral pain to cancer pain, throat pain, for everything. This is a master framework and categorization, indications and contraindications and pearls of commonly used analgesics in clinical practice. This video is completely for educational purposes. This is Medicine Beyond Harrison's, and let's get started. So we'll discuss this into five-step model. One is the mechanism and class of each of the analgesic, when to use what analgesic, when not to use, which is what is most important. When not to use, as far as analgesics is concerned, we must know when not to use a certain analgesic and must know facts about each analgesics and its side effects. Agenda is non-opioids, which consists of NSAIDs and paracetamol. Opioids, we categorize into the weak and strong. Then other adjuvants like neurological analgesics like pregabalin, gabapentin, and local and regional analgesics, and in special scenarios. We'll get started into non-opioid. Firstly, paracetamol, the most commonly used drug for analgesia as well as antipyretic. So analgesic dose is higher than the antipyretic dose. Mechanism is central COX inhibition and it acts as an antipyretic as well as analgesic. It has no significant anti-inflammatory effect as compared to the other commonly used NSAIDs. So when to use? It can be used for fever, mild to moderate pain, headache, viral pain, body pain. It is a very good analgesic in this regard. It is the most safest of all the analgesics. It is safe in pregnancy, children, as well as in elderly. So once we go into other analgesic medications, then you will know the safety features of this drug. It is the first line in CKD patients, heart failure patients, and on patients who are on anticoagulation. Contraindications is mainly in severe liver disease, that is child pug classification class 3, and active alcoholic liver disease. In even these kind of patients, in liver disease patients, cirrhosis patients, you can go up to a maximum of 2 grams per day. Maximum dose is 4 grams per day for normal individuals. Saferly, we consider 3 grams per day for chronic use. The toxic metabolite is NAPQI, which is N-acetyl paraquinonamine, which is the toxic metabolite, which leads to depletion of glutathione and liver toxicity. So to prevent this, we can supplement with glutathione in paracetamol poisoning as well as N-acetylcysteine. So non-selective NSAIDs, we come to mainly ibuprofen, diclofenac, naproxen, indomethacin. So these have both COX-1 and COX-2 inhibition. It is very important and one of the most useful drug for inflammatory pain, that is in arthritis, rheumatoid arthritis, osteoarthritis flare, and one of the most useful drug in renal colic. It's diclofenac IM. For dysmenorrhea, naproxen, mefenamic acid. For acute gout, indomethacin. Indomethacin is the guideline recommended drug for acute gout. So when not to use, this is the most important thing that we need to understand regarding NSAIDs, particularly non-selective NSAIDs. It is not recommended for use in CKD, acute kidney injury, cardiac disease like congestive heart failure, and coronary artery disease. These drugs are very much cardiotoxic. So GI disease, ulcer, bleed, GERD, you should not use NSAID. This can cause ulcer bleed as well as exacerbation of GERD. Could not be used in decompensated cirrhosis. Third trimester of pregnancy will lead to patent ductus arteriosus, that is closure of the ductus prematurely. Then when on concurrent anticoagulation, these cannot be used, which will lead to increased clotting tendency. So literally, when one another organ system is involved, be careful in giving non-selective NSAIDs. Preferably, do not use non-selective NSAIDs. So NSAIDs, pearls and side effects, preferably use naproxen. It is the most cardiovascular neutral. It is the safest drug for the heart. So preferably use naproxen if available. If not, then consider other non-selective NSAIDs like indomethacin in specific situations. It has high CNS effects, so not preferred in headache and confusion kind of pain. So diclofenac, that's the most cardiotoxic NSAID is diclofenac. So avoid in established coronary artery disease. Ibuprofen is the best GI safety among non-selective NSAIDs. And the major side effects are acute kidney injury, which will lead to specifically acute tubular necrosis, sodium retention, GI bleeding, and gastritis. In cardiovascular thing, it is edema. It can itself induce myocardial infarction as well as strokes. So let's go into COX-2 selective, which is atopic oxib and celecoxib. These atopic oxib and celecoxib are more cardiotoxic than non-selective NSAIDs, but our use is in patients with GI risk. If the patient is having a GI risk, then we can use non-selective NSAIDs for arthritis and post-op patients. Contraindications is established coronary artery disease, stroke, peripheral vascular disease, severe renal and hepatic dysfunction. So preferably use only if there is a GI problem and no other comorbidities. You can use etorecoxib or celecoxib. Aspirin, it is a low dose of aspirin is used for antiplatelet, which is universally used for cardiovascular prevention. It is rarely used nowadays for analgesia because of its toxicity. In children, it may lead to Raynaud's syndrome. In adults, it may lead to exacerbation of asthma and nasal polyps and can lead to bronchospasm. It is a irreversible COX-1 inhibitor, so it has an effect of platelet inhibition for 7 to 10 days. So next we go on to opioids. So based on the previously discussed topics, we discussed the NSAIDs, which is COX non-selective and COX-2 selective, as well as on paracetamol. Uh, Once these drugs are not being able to use, or when the pain is not manageable with these drugs, then the next we go for opioids, preferably the weak agents, which are tramadol and tapentadol. Tramadol is one of the yet another most commonly used analgesia in inpatient setting as well as in outpatient setting in selected patients. It has a weak mu agonist and SNRI action. It is used for moderate pain with neuropathic overlap. Main disadvantage is it can induce seizure as well as serotonin syndrome. Always be careful if a patient is having a CNS issue. Preferably no, do not use tramadol. It itself can cause headache. So, headache patients, for example, a patient having a meningitis or a patient having aseptic meningitis due to enteric fever or central toxic headache due to typhoid. In these kind of patients, if you use tramadol, it itself can exacerbate the headache as well as it can induce seizure. So, preferably avoid tramadol for headache. It can be used for, if it cannot also be used with SSRI and SNRI. It can itself induce serotonin syndrome. Tapentadol is the next generation for the weak opioids. It has partial mu agonist action as well as norepinephrine reuptake inhibition. It is used for diabetic neuropathic pain and acute postoperative pain, as well as cancer chemotherapeutic pain. Advantage is just it has less serotonin effect, so lower incidences of serotonin syndrome risk than tramadol. So next we go on to strong opioids, which is morphine, the gold standard drug, which is considered to be the opioid for acute chest pain, for myocardial infarction pain, any traumatic pain, post-operative pain, for palliative care patients, for cancer pain, for everything, morphine is the drug of choice. It has a lot more side effects like respiratory depression, constipation. See, all opioids have features of constipation. Even tramadol and tapentadol can lead to constipation. So if there is a constipation, kindly avoid using Tramadol or Tapentadol as well as morphine. So it itself can cause nausea, pruritus. So basically, a patient who is drowsy and low BP, in these kinds of patients, preferably do not use morphine as an analgesia. So it will further lead to respiratory depression, it will lead to metabolic respiratory acidosis, as well as lead to cardiorespiratory arrest. Mainly when not used morphine. When CKD or renal failure patients, active metabolite M6G accumulates, which will further lead to neurotoxicity and coma. So avoid morphine use in CKD or renal failure patients. In head injury patients, there will be more CNS depression and there will be less respiratory drive, hence there will be CO2 retention, there will be vasodilation, and increased ICP. Always you avoid morphine in severe asthma, which will lead to exacerbation of asthma also. So fentanyl is 100 times more potent than that of morphine. It has various advantages as compared to morphine. It can be used in renal failure patients. It is the safest as well as the strongest opioid. It has no active metabolites. It can be used for, it has hemodynamic instability patients also. It can be used because it has no histamine release, cardiac safe. So for patients who is on non-adrenaline support or and on mechanical ventilation, for mild sedative action, fentanyl is the preferred drug of choice. For procedures in ICU, for ICU sedation, for everything, fentanyl is the drug of choice. For chronic cancer pain, 25 milligram of fentanyl can be given as a patch, can go up to 50 or 100, which will decrease the cancer pain. One of the most used drug for cancer pain. Warnings, it is not used as a patch for acute pain. It can be used as an infusion for acute pain. It can lead to chest wall rigidity or rigid chest syndrome or wooden chest syndrome. If used as IV bolus too fast, it can lead to respiratory depression and respiratory arrest. So other drugs in opioid category are oxycodone and methadone. These drugs are more potent than morphine. Can be used for severe pain when morphine is not tolerated. It's better for neuropathic component than morphine. It has oral formulations also. Methadone is used for chronic opioid tolerant pain, de-addiction from morphine. Mechanism is mu agonist plus NMDA antagonist, great for neuropathic pain. The problem with methadone is unpredictable half-life and QT prolongation can lead to torsity pointis in a rare case scenario. So coming to after finishing opioids, we come to the next set of pain medications such as neuropathic agents. These agents are gabapentinoids, duloxetine, and amitriptyline. These are mainly for neurological and nerve pain. So gabapentinoids are two gabapentin and pregabalin come at 75 milligram, can go up to 300 milligram per day. It is used for diabetic neuropathy, post-herpetic neuralgia, fibromyalgia, severe osteoarthritis. So it has a mild sedative effect, which is the prominent side effect, can lead to dizziness, peripheral edema. It's always ensure to start low, preferably 25 or 50 milligram per day at night, preferably at 6 p.m. so that the patient goes to to bed by 9 or 10 p.m. When they wake up, they will have less sedation. Always remember to adjust dose for renal failure patients. So next is duloxetine, which is an SNRI. It is used for diabetic neuropathy, chronic back pain, osteoarthritis. So ensure to avoid in liver disease and EGF for less than 30. So when the liver and kidneys are affected, avoid duloxetine. So side effect is nausea, hypertension, and insomnia. Amitriptyline is a tricyclic antidepressant. It is also used for neuropathic pain. Uh, because of tricyclic antidepressant effect, it can lead to QT prolongation, elderly, then coronary artery disease. Can also lead to anticholinergic effects like dry mouth, urinary retention, sedation. So keep in mind to not use amitriptyline in elderly patients who are prone for urinary retention, dry mouth, or on frequent excessive recurrence of urinary tract infection. Avoid use of amitriptyline. So other drugs are carbamazepine, mainly currently used for trigeminal neuralgia and seizure disorder. Always ensure to check for HLA B1502 in Asians to prevent Steven-Johnson syndrome. Rare side effects include bone marrow suppression and autoinduction of metabolism. So carbamazepine has a lot of drug interactions and also can lead to bone marrow suppression. Always use with caution. So local and regional anesthesia can be done with lidocaine with local infiltration, nerve blocks, IV infusion for refractory pain. It can lead to tinnitus, seizures, and arrhythmia. Capsaicin can also be used for topical or for localized pain. So various other special clinical scenarios where pregnancy and paracetamol is the go-to drug of choice for analgesia. Avoid NSAID in third trimester can lead to premature closure of ductus. And always avoid chronic opioids for pregnancy. So in cirrhosis patients, preferred and highest analgesia is fentanyl, and the next preferred drug is low dose paracetamol up to 2 gram per day. Avoid NSAIDs can lead to hepatorenal syndrome. Avoid morphine. So for CKD and renal failure patients, preferably paracetamol, fentanyl, and methadone. Ensure to avoid NSAIDs can lead to renal shutdown. Avoid morphine and gabapentin unless doses adjust. The coronary artery disease and stroke, preferably naproxen, along with pantoprazole or other PPI. It has the lowest cardiovascular disease risk as far as NSA is concerned. Ensure to avoid diclofenac or COX-2 inhibitor at any cost. So analgesia is not about potency; it is about the patient's profile. So we have to ensure the patient is not having the comorbidities and are fit for analgesia and the appropriate analgesia to be considered for pain relief. So match the metabolism to organ function. That is, the renal and hepatic dysfunction should be considered before giving any analgesia to the patients. Anticipate side effects like laxatives. That is, if the patient is on opioid analgesia, the patient will experience constipation and put them on laxatives. If on NSAIDs, always ensure to put them on PPIs. So this is Medicine Beyond Harrison. We will meet at another video. Thank you for watching.